For decades, you have been told the same thing. Take your blood pressure pills. Take them every single day, no exceptions. Your doctor said it, the guidelines said it, and you listened, because that is what responsible patients do. But something just changed. Quietly, without a single headline on the evening news, the biggest cardiology organizations in the world just admitted something that should stop every senior in their tracks. For 11.4% of older adults currently on blood pressure medication, those pills may be doing more harm than good. Not helping, not neutral, actively working against you. And the question you need answered right now is simple. Are you one of them? What I am about to explain could fundamentally change the conversation you have with your doctor at your next appointment, but only if you stay with me for the next 18 minutes. Because by the end of this video, you will know exactly what changed in the newest blood pressure guidelines, whether this reclassification applies to you personally, and the exact words to say when you sit down in that exam room. I will even give you a step-by-step protocol you can start using this week. I'm Dr. Richard James, a senior health expert with over 3 decades of clinical experience, and I need to walk you through something that has just shifted the ground under millions of seniors' feet. For 8 years, the standard was simple. If your blood pressure was above 130/80 and you were considered high risk, you got medication. Period. That threshold was set in 2017 by the American Heart Association and the American College of Cardiology, and for nearly a decade it was treated as gospel. Millions of prescriptions were written based on that framework. Millions of seniors took their pills every morning without question. And most doctors never revisited the decision, because the guidelines told them not to. But those same organizations, along with 11 additional medical societies, 13 in total, just released a completely new guideline. It was published in August 2025 in JACC and Circulation, the 2 most authoritative cardiology journals on the planet. This is not a minor tweak. This is not a revised footnote. 13 medical societies signed off on this. That includes the American Geriatric Society, the American Medical Association, and the Association of Black Cardiologists. This is the cardiology establishment saying, for some of you, we need to change course. And at the center of this new guideline is a tool that changes everything. It is called the PREVENT calculator. When researchers ran existing patient data through this new system, they found that more than 1 in 10 seniors were being medicated unnecessarily. That is not a minor adjustment. That is millions of people taking pills every morning that may not be protecting them and might actually be hurting them. But the real question is not what changed on paper. The real question is what this means for the pills sitting on your counter right now. And to answer that, I need to explain something most doctors have not had time to walk you through yet. Here is what happened. For years, your doctor has been using something called the Pooled Cohort Equation to estimate your cardiovascular risk. Think of it as a calculator. You plug in a few numbers, your age, your cholesterol, your blood pressure, and it spits out a score that tells your doctor whether you need medication. The problem? That calculator was built in 2013. It was based on a limited data set that did not reflect the full diversity of the American population. It did not account for your kidney health. It did not factor in whether you had diabetes or metabolic syndrome. It did not adjust for markers like hemoglobin A1C or estimated glomerular filtration rate. Those are kidney and metabolic indicators that we now know matter enormously after 60. And critically, it consistently overestimated risk, in some cases by as much as 2-fold. That means for years, some seniors were being told their risk was twice as high as it actually was. Think about what that means in practical terms. Your doctor looks at the calculator. It says your 10-year risk of a heart attack or stroke is 12%. That is above the treatment threshold. You get a prescription, you fill it, you take it every morning for the next decade. But your actual risk? It may have been closer to 6%, below the threshold. You may never have needed that prescription in the first place. The PREVENT calculator replaces this entire system. PREVENT stands for Predicting Risk of Cardiovascular Disease Events. It was built on data from more than 6 million patients across diverse populations. It factors in kidney function, metabolic health, statin use, and even social determinants of health using zip code data. Unlike the old equation, it also estimates your risk for heart failure, not just heart attacks and strokes. It looks at you, the whole picture, not just 3 numbers on a chart. And when researchers plugged real patient data into this new, more complete system, they found that millions of seniors had been classified as high risk when they were not. Specifically, 11.4% of adults aged 65 to 79 with stage 1 hypertension, that is, blood pressure in the 130 to 139 over 80 to 89 range, were reclassified as lower risk. Under the old system, they qualified for medication. Under the new system, they do not. That pill you take every morning? It was prescribed based on the old math. And the old math was wrong for a significant number of people. So now you understand what changed and why it matters. But here is the part that makes this personal. Because the question you are really asking is, does this apply to me? Stay with me, because I am about to walk you through exactly who falls into that 11.4%. Let me tell you about Margaret. She is 72, retired school teacher, walks her dog every morning, no diabetes, no kidney disease, no history of heart attack or stroke. Her blood pressure sits at 134 over 82 on 2 medications. One she has taken since her early 60s, the other added 5 years ago after a slightly elevated reading at her annual physical. For 11 years, nobody questioned whether she still needed both. Her doctor renewed the prescriptions every visit. Margaret never asked, because she trusted the system. When we ran her numbers through the new Prevent calculator, her 10-year cardiovascular risk dropped below the treatment threshold. She did not need that second pill. She may not have needed it for years. Within 6 weeks of reducing to a single medication, Margaret reported something she had not felt in a long time. Energy. Real, sustained energy. The dizziness she had been dismissing as just getting older disappeared. She stopped gripping the handrail every time she stood up from the couch. She told me, and I will never forget this, I didn't realize how bad I felt until I started feeling better. Now, Margaret is a composite, a representation of the pattern I see in my practice every single week. Seniors who have been on the same 2 or 3 blood pressure medications for 10 or 15 years, and nobody has ever reassessed whether they still need all of them. So who is most likely to be reclassified? Pay close attention. If you are over 65, your blood pressure is reasonably well controlled. You do not have diabetes or chronic kidney disease. You have never had a heart attack or stroke, and your blood pressure sits in that 130 to 139 over 80 to 89 range. You need to hear what I am about to say next, because your body after 60 processes these medications differently. Your kidneys filter more slowly. The drug stays in your system longer. And that means the same dose that was safe at 55 might be pushing your blood pressure too low at 72. And it is worth noting that the people most likely to be reclassified are women. According to the chair of the Guideline Writing Committee, it is rare for a man over 65 with stage 1 hypertension to not have additional risk factors. Women without those comorbidities are the group most affected by this change. So now you know what changed, and you have a good sense of whether this applies to you. But before I give you the exact protocol, what to say to your doctor, what to request, what to expect, I need to show you something that most people do not realize about staying on blood pressure medication you no longer need. Because the risks are not trivial. This is the part that should genuinely concern you. Every year, falls send more than 3 million seniors to the emergency room. In 2023 alone, over 3.85 million older adults were treated for fall-related injuries. And in 2024, more than 43,000 adults over 65 died from preventable falls. Falls are the leading cause of injury death in this age group. That is not a statistic you can afford to ignore. And one of the most common, most preventable triggers? Blood pressure medication pushing numbers too low. It is called orthostatic hypotension. You stand up from a chair. Your blood pressure drops suddenly. Your brain does not get enough blood for just a moment. The room tilts. Your legs buckle. And that moment, that single second of dizziness, is enough to send you to the floor. Enough to break a hip. Enough to change the entire trajectory of your independence. But falls are only the beginning. When blood pressure is driven too low in older adults, the kidneys suffer. Some blood pressure medications, particularly diuretics and ACE inhibitors at doses that made sense when they were first prescribed but no longer do, can paradoxically impair kidney function over time. Diuretics can also deplete critical electrolytes like potassium and sodium, leading to muscle weakness, confusion, and irregular heartbeat. And then there is the cognitive concern. Emerging research suggests that in frail elderly patients who are overtreated below safe thresholds, reduced blood flow to the brain, what doctors call cerebral hypoperfusion, may contribute to faster cognitive decline. I want to be very clear about this. Blood pressure treatment in general saves lives. The SPRINT trial proved that beyond question. This is not an argument against treating high blood pressure. This is specifically about overtreatment in people who no longer need as much medication. There is a critical difference between treating a real risk and medicating a risk that no longer exists. And here is what the evidence says about reducing medication safely. This is not guesswork. This is backed by some of the strongest clinical trials in the field. A landmark trial called OPTIMIZE, published in JAMA in May 2020, followed 569 patients aged 80 and older across 69 primary care sites in England. These were patients on at least 2 blood pressure medications with well-controlled blood pressure. Researchers removed one medication from the treatment plan and monitored the results for 12 weeks. What happened? 86.4% of patients in the medication reduction group maintained blood pressure control, almost identical to the 87.7% in the group that changed nothing. No significant differences in side effects, adverse events, or quality of life. And the long-term follow-up, published in The Lancet Healthy Longevity in July 2024, confirmed that half of participants sustained that medication reduction with no increase in hospitalization or death. A larger trial called Retreat Frail, published in the New England Journal of Medicine in August 2025, took this even further. Over 1,000 nursing home residents aged 80 and older across 108 facilities in France were followed for up to 4 years. These were frail patients, the very population doctors worry about most. The result? Reducing blood pressure medication did not increase heart attacks, strokes, or death. The mortality rate was virtually identical between the two groups, a hazard ratio of 1.02. That is as close to no difference as clinical research gets. The medication was supposed to protect you, but protection only works when the threat is real. And for 11.4% of seniors, the threat was overestimated by an outdated calculator. And here is the part that changes everything. Because knowing you might be over-medicated is one thing. Knowing exactly what to do about it, that is what separates people who worry from people who act. Now, I know what some of you are thinking, and you are right to question this. My doctor told me never to stop my pills. Good. Listen to your doctor. I am not telling you to stop anything on your own. Nobody should ever stop blood pressure medication without their doctor's involvement. What I am telling you is that the system your doctor used to prescribe that medication just changed. And that means the conversation needs to be updated too. This is not about going rogue. This is about bringing your doctor new information that did not exist when your prescription was first written. But what if my blood pressure goes back up? That is a legitimate concern. And the answer is, you monitor. Deprescribing is not quitting cold turkey. It is a supervised, gradual process. Your doctor reduces one medication at a time, checks your numbers at 4-week intervals, and adjusts. The OPTIMIZE trial showed that in properly selected patients, the vast majority maintained control. These guidelines do not apply to me. I have other conditions. You may be right. If you have diabetes, chronic kidney disease, or a history of heart attack or stroke, the guidelines still strongly recommend medication. This deprescribing conversation is specifically for the subset of seniors whose overall cardiovascular risk, when recalculated with the new PREVENT equation, drops below the treatment threshold. So here is exactly what I want you to do. This is the protocol I give my patients, and I want you to follow it precisely. Step 1. At your next appointment, or call and schedule one this week, say these exact words to your doctor. I have learned that the AHA just updated the blood pressure guidelines with a new risk calculator called PREVENT. Can we reassess my cardiovascular risk using this new tool? You do not need to memorize the science. You do not need to bring a research paper. Just ask the question. The Prevent calculator is free, available online at the AHA's website, and many electronic health records are already integrating it. Your doctor will know what you are talking about. Step 2. If your recalculated 10-year risk falls below 7.5%, ask the follow-up question. Based on these new numbers, do I still need all of my current blood pressure medications at these doses? That single question opens the door to a conversation that could change your daily routine for the better. Step 3. If your doctor agrees to deprescribe, expect a gradual process. This is not something that happens overnight. One medication is reduced at a time. Your blood pressure is checked at 4-week intervals. Adjustments are made carefully. And here is something practical that will make this process smoother. Get yourself an automated upper arm blood pressure cuff. Not a wrist monitor, those are less accurate. Measure every morning, same time, before you take any medication, after sitting quietly for 5 minutes. Write it down in a notebook or on your phone. Bring that log to every appointment. That data gives your doctor the confidence to make safe adjustments. Step 4. Track 3 things during this process: your morning blood pressure readings, any dizziness when standing, and your energy levels throughout the day. Those are the earliest signals that the adjustment is working, or that something needs to be reconsidered. If your numbers stay stable, if the dizziness fades, if your energy improves, that is your body telling you it is responding well. The most powerful thing about this guideline change is not the calculator itself. It is the permission it gives you to have a conversation you may have been afraid to have. You are allowed to ask whether you still need every pill on your counter. That is not being difficult. That is being an informed patient. You were told to take your pills. You were told not to question it. And for years, that was the right advice. But the science moved, the guidelines moved, and now it is your turn to move with them. If there is someone in your life, a parent, a spouse, a friend, who takes blood pressure medication every day and has never been reassessed, share this video with them. Send it in a text. Mention it over the phone tonight. You might be the reason they have the right conversation with their doctor this month, and that conversation could change everything for them. I'm Dr. Richard James. Subscribe because next week I'm covering the 3 blood pressure medications that cause the most side effects after 65, and most doctors never mention it. Take care of your heart tonight. I'll see you in the next one.